Well, good morning or good afternoon, wherever your time zone may be, and welcome to this presentation on customizing your QAPI to meet your strategic and operational objectives. My name is Margherita Labson, and I'm the Executive Director of the Joint Commission's Home Care Program, and it's my pleasure to present this webinar today in conjunction with the VNAA as part of our continuing commitment to work with them to improve the quality of health care being provided to the public. Let's begin. At the completion of this program, I have three objectives for you as the audience participants. First of all, I would like you to be able to identify the components of your quality assessment and performance improvement plan that target specifically value-based program and payments, and then describe strategies that can help you meaningfully analyze your data, and finally, explore how to focus on high-priority areas that will impact this value-based program. The foundation for a quality assessment and performance improvement plan really targets the value-based payments in several different ways, but I wanted you to understand that foundationally this is grounded in the Affordable Care Act. As you know, the Affordable Care Act has essentially the aim of improving health to the patient populations, improving the patient's experience of care, and finally reducing the overall cost of care per beneficiary and ultimately to the system. When you identify the components of a quality assessment performance improvement plan that really targets value-based payment, you need to understand and look at this segmentally, because otherwise it almost seems overwhelming where to begin. So begin first of all with what is going to be valued in these value-based payment plans. There's a lot of people that talk about value-based payments, but at the end of the day, what are these values that they're talking about that are going to be used to ultimately determine payment, your payment options? Now, there has been some initial definition of it, and quite frankly, we're just beginning down this road, so it's, in many instances, it really benefits you to stay on top of this information, because as we move down this pathway to this value-based payment program year by year, month by month, we're going to see nuances develop, revisions, refinements to the program. But ultimately, when you are beginning down the road of value-based payment, and gosh knows if you're in Florida or in Massachusetts or some of the other states, you're already there, you need to understand what values are going to be used that are going to define your payment options. Values ultimately result in, they're driven from certain standards. They're either evidence-based standards or in many instances they may be largely consensus-based. But what standards are you being measured against? And then how is it going to be measured? And my message to you here is, if you're in a value-based payment system, whether it's by a payer or whether it's by CMS, the largest of our payers, you really need to understand how is it being measured. And I bring this to light because many times organizations will have multiple payers. You have a diversified payer stream. And what happens is they are measuring you on readmission rates. But how that metric is measured, how they calculate that readmission rate, may be slightly different between payers. So you need to understand how to do the measurement correctly so that you don't put yourself in harm's way by measuring everything in the same fashion. So please be sure that when you're getting underneath the standard to which you're being measured, that you understand clearly how they're defining it for you. And then some key indicators. So for our purposes here to try and help you understand it, the value-based payment really is driven by a standard of performance. In that standard of performance, it usually relates to a process or an outcome. You need to understand what are the key indicators, the key performance indicators, KPIs we refer to them as, that help drive the achievement of that standard. Where I happen to work, we call those elements of performance. These are the critical building blocks that you need to always be in place and working consistently in order to have a reasonable chance of consistent, reliable performance to a standard. Now, In terms of the metrics of our current value-based payment program as it's been laid out, we know that they're going to address 6 national quality strategies, and there's 6 priorities that are involved there. So you see them on the screen in front of you. There's clinical care, safety, certainly no surprise to any of us. Then there's efficiency and cost reduction. That, for some organizations, can be new because it really is beginning to link operations with clinical. And I began in home care nursing many years ago, back in the mid-70s, and in those days nurses were very fond of saying, well, I'm not worried about the cost. My responsibility is only to patient care. And now it's not just about patient care. It's about, doing the right thing in the right way at the right time. And we all realize now that in order to deliver good patient care, you really have to be responsible and a judicious steward of the resources that are entrusted to you. Person-centered or patient-centered experiences and outcomes is another key priority, and this is another area that is not yet well understood by many providers. We like to think of ourselves as being patient-centric and very person-centered, but at the end of the day, you really have to put yourself in the shoes of that particular patient or person. So let me give you an example that happens in some instances quite frequently. Organizations struggle to provide perhaps speech therapy or occupational therapy on a regular basis. There's a shortage in their particular area, and as a result, patients can only receive their therapy at 4:30 or 5 o'clock in the evening when the therapist is now working on your behalf as opposed to perhaps working at the hospital or working in clinic. If you have a patient who is recovering from a CVA and the only time of day that they can receive their occupational therapy or their speech therapy that's doing perhaps cognition therapy with that particular individual, that may not be the best time for that particular patient to receive it. They may be tired from the end of the day. We do know that there's a tremendous expenditure of energy, and so as a result, that patient is not really satisfied with with receiving the care and services at that time of the day, but that is the only time you can provide it. Now ask yourself, is that really a patient-centered experience, or is that a provider-centered experience? Logically, the answer would be it's a provider-centered experience because the provider is limited in their ability to service that patient at a time when it would be opportune for them to receive those services. So be aware of those things as you move downstream, because a lot of times organizations are going to be measuring patient-centered experience and not really being able to get underneath it. Your best repository for that information is going to be your satisfaction surveys or your net promoter scores there. Care coordination, and of course population health. Now, it's important to realize that all the measures are equally weighted, and you'll see there are 4 categories on which they are weighted. And you'll also need to realize that you're rewarded basically on 2 metrics, and that's achievement and improvement. And that's an area that's still being debated, because if you're already a high-performing agency in terms of your achievement, your ability to improve becomes appreciably more challenging because you're already up there. By the same token, in order for, if you're a very large agency, it becomes challenging to move that dial. So make sure, again, when you're setting those metrics for yourself and you're looking at that you understand what it takes to move the dial on improvement and clearly where your threshold is for achievement. In terms of the measures that will ultimately determine the performance, you'll see there that they're being drawn from multiple sources, and that's really to make the value-based payment a robust picture. So we also, in the corner there, I put 3 new measures: influenza vaccination, herpes zoster for patients, and advanced care planning. At this particular moment in time, they're not being factored in. They will in future. But I want you to understand that much of this is, as you can see, the influenza and the herpes zoster is really preventative. If you happen to be accredited with the Joint Commission, you know that that's already a requirement, and certainly if you're otherwise accredited or not accredited at this time, realize the implications both operationally and for the quality of patient care if you don't have a robust influenza vaccination program. The cost of that and the ROI on having one of those types of programs can be a substantial cost savings for a particular home care organization. It can also help reduce your hospital readmission rate in a significant way, and that obviously makes you a more valued provider partner. The CDC has very robust resources for you, and of course if you happen to be accredited with the Joint Commission, you can use all the resources in the portal that are available to you. The same thing for the herpes zoster for patients. The CDC has a lot of information there. And advanced care planning, there are any number of sources that talk about that, but that really begins to address the need for the appropriate advanced care planning to refer patients into palliative care and or hospice care services as may be appropriate. Again, all about the right side of care for the right patient at the right time. Now, measures really come in three shapes and sizes. You have a direct one-to-one measure, which would either be a process measure or an outcome measure. So I gave you two examples there. A multi-factor risk assessment is conducted, and then unplanned admissions, typically within 60 days. That's the outcome. The composite measures are a series of measures that come together, and they form sort of a picture of a particular event. So we have how communication exists between the providers and then the care of patients. And then the most challenging one, which is the global, and that's your patient's overall rating of your organization and the likelihood to recommend. The likelihood to recommend, another great way of saying that, is your net promoter score. And there's a resource at the end of this webinar to show you where you can go and learn more about Net Promoter Score. It's one we use where I work. So let's think about that. When we think about setting up your quality assessment and performance improvement program to target your value-based payment goals, we really need to understand the implications that go before it hits operations. And so when we look at that, we think about the standards for leadership. And I'm just pulling from information that I have from where I work. But certainly there's a lot of resources out there in the field about what are the standards for leaders and leadership. Where we work and the providers that we work with, we say, you know, one of the standard for leadership is that the organization's leaders have a responsibility to use data information to guide their decisions. And certainly that's drawn from consensus-based and evidence-based information that's out there regarding the performance of leaders. Harvard Business Review can give you information on that. There's any number of sources. Of course, we would always encourage you to look for reputable sources of that information. So when you think about that standard existing, what are elements of performance? What are the key performance indicators that would help an organization's leadership always make sure that they are performing to that standard? We've identified 4. We say you've got to set the expectations for how the data is going to be used. You have to use and support the systematic data and information use. You have to use the data to make your decisions. You can't get data in and then ignore it, because that defeats your purpose, and that will lead to you not achieving that standard. And finally, you have to step back as a leadership team, and you have to evaluate how effectively do we use our data. Do we let opinion roll over us and then make the decision? Or were we faithful and true to the data? Did we do what it said? And perhaps, we've identified an additional opportunity. Another standard that a leader would have to do in order for them to plan to set up a value-based payment-related goals is the leaders have to establish some priorities. One of the biggest disconnects that you see in organizations that are naive to this type of a process is that the leaders are sort of isolated from operations, and they sort of abandon, if you will, their responsibility and accountability for really identifying and establishing priorities for what systems and processes need to drive performance improvement. So as leaders, they need to identify what are the priorities. Otherwise, there's a huge disconnect between management and leadership. And leadership is making strategic decisions on what service lines we're going to enter, what contracts we might enter into, and then you have operations that is responding to day-to-day activities and may not understand or see the bigger picture. So set your priorities around patient outcomes, then help and give priority to those that are high risk and problem-prone processes. So let me just give you an example. One of the areas that seems to be problem-prone is this med reconciliation, and many of the IT systems today have med reconciliation built in to their platforms. They help the computer-based software programs really help clinicians in the field do the med reconciliation. However, an organization may purchase a software program through a computer system, and the IT systems are usually, the IT companies are usually very clear with, listen, it's going to take your teams about 2 years to fully operationalize and optimize the use of the software program. But what you see the leadership doing is that they don't really give priority to the training. They somehow think that if they give them a 90-day or a 90-day or a 6-month training time frame, that they should all be expert on this. And what ends up happening is that training falls by the wayside because it's not prioritized by leadership. So if it's not prioritized by leadership, it's not prioritized by management. The clinicians don't prioritize it. And then leadership becomes frustrated and dissatisfied with the IT provider or with the staff because here the program that they've devoted significant resources to purchasing isn't working correctly. In order for that to happen, then the leaders have to sustain the priority. They have to recognize it as problem prone. They have to prioritize it so that the management is able to then continue the monitoring and the measuring of that activity and achieve the goal that they've set out for themselves. In this case, it would be like medication, the documenting of the medication reconciliation. And then, of course, to reprioritize. Nowhere is it written that the plan that you put in place in January has to be the exact same plan in place that you have in April or June or September. Periodically reviewing and reprioritizing is a necessity, and the leaders have responsibility for leading that, for championing that. So here we are back to the same piece, and I just wanted to now take that same infographic and kind of switch it up a little bit to kind of show you how that process would work. So leadership sets the expectations that the agency is going to successfully convert to the value-based payment program. Your QAPI coordinator is going to work with the leadership to determine what their strategic goals are and then translate that with the management into some key operational metrics that they're going to have to do in terms of measuring and monitoring processes and outcomes. And those key indicators will be translated into the value-based payment measures, into the metrics that they're going to monitor. And they're going to determine at what frequency. Frequency is an important piece. The more important your metric, the more frequently you should measure it. So if you are trying to measure things, let's say by your value-based payment, you're contractually obligated to admit a patient within X number of hours from the time that that patient becomes available for care, then you most certainly want to measure that that particular metric no less frequently than every week, because you need to have an understanding if you're trending up or trending down, or you're well within your normal frequency of variation. Process-based measures, I just gave you an example here, this multi-fall risk assessment is being conducted. So again, think about what are the elements of performance, what are those key performance indicators that you need in order to achieve a standard that says we are always conducting multi-factor fall risk assessments. Well, I've identified 4 for you here. First of all, you need to have a competent clinician. You have to have a defined process for conducting that service, that particular fall risk assessment, a consistent orientation, and effective supervision. Now, I want you to notice something here. Nowhere on this measure set do you see I am auditing any charts. Nowhere. At this particular moment in time, I've just identified 4 clear metrics. That means that I am definitely going to be looking at somebody's personnel record to see, is there a competent clinician? Have I done the orientation in accordance with expectations? Have we determined whether or not this clinician is capable of doing that fall risk assessment? Do we have a defined process? Now, in some organizations, a defined process means somewhere, somehow, it's got to be written out. So some organizations have a policy, but I'll bet every one of you listening to me today has an assessment, a fall risk assessment program that is written out somewhere. It could be written out electronically in your software program, or if you're on a paper record, it could be in a paper form. At the end of the day, that's a defined process, okay? So how are you getting it done? Now, the only way that you're really going to be able to identify whether or not that's happening consistently is at some moment in time you're going to have to watch a clinician do it to see if they're doing it. You can certainly do it at the completion of their orientation if you're testing out and watch them do it, but you do have to watch it. And then effective supervision. And that's a tough one because think about, we're really good at orienting and training our first line staff, but how good are we at really upgrading and training and continuing the education of our supervisors? In many instances, what we find is if they were a good nurse in the field, they get promoted into the supervisory position, but that doesn't always mean that they've been trained to supervise. And there's a different skill set that's involved there. Now, many organizations are coming to realize that. They're devoting more energy and time and resources to really professionally developing their supervisors so that they're capable of observing, interviewing, and evaluating performance. And I want to encourage you, if you've not done that, if you've perhaps just assumed the role that if they're good in the field, they'll be a good supervisor, I want you to encourage to revisit that belief, especially in this time of value-based payments, because that's not necessarily the truth. And then, of course, I talked to this a little bit just a few minutes ago about tracing the process to identify gaps. I'm very fond of saying if you have a situation where med reconciliation is not going on in accordance with your expectations, you're never going to get the answer to why that's happening by simply auditing med profiles in offices. You've got to watch the process. You've got to actually, at some moment in time, determine that. That doesn't mean that you've got to watch it 20 times. We always say the smallest sample you could really do in most agencies would be a sample of 20 audited records. That doesn't mean you have to do 20 visits. But clearly, you have to do a sampling of your staff to determine what is the process. And you have to interview that staff to help that, to understand what their belief system is and look for identified gaps in the process. So let me just show you a multi-factor risk assessment. Here's just one. This is, as you might recognize it, it's an Ishikawa or a fishbone diagram. What you do is I've taken those key performance metrics, management, the processes, policy and program, people, tools, and environment. Now, if I was doing this for one of the agencies that I worked for as a PI, all of these areas would be filled in and it would identify key performance indicators of the process, the policy, and program. What I've done for you here is just to identify those areas that were not working well. So management, in this instance, the multi-factor fall risk assessment was not being done in accordance with the expectations of the organization. And when we drilled down to it, this is what I found. That first of all, even though it was supposedly prioritized, what was really being prioritized, what was being heard by the clinicians as being prioritized is you only have an hour to do a start of care or a rock. That's all you have. So you better get it done because all you're being allotted for is an hour. The other thing that was a key factor that wasn't in place that was leading to the disconnect was that many times supervisors were not really being faithful in their supervisory tasks, and they were accepting partial documentation as satisfactory until the PI went behind them, and if they got a chance and happened to pull that record, then it was identified as, oh my gosh, it wasn't done. And finally, as a result of that subtle nonverbal communication gets down to the clinician's level, and so what was happening was clinicians on a scale of 1 to 10 rated the fall risk assessment as a 4. It was not the most important thing, which was interesting on a scale of 1 to 10 because we asked them to rate 10 different factors. So the multi-factor fall risk assessment was not being done. It was very frequently incomplete, but the reason why wasn't because they didn't have a process, and it wasn't because they didn't have a policy, and it wasn't because they didn't have tools. Everything else was in place. What was in place was the subtle message that was getting from management down to the people was that it really wasn't valued, and they were being accepted as partially done, and you only have an hour to get the start of care done, so get it done. So you as a colleague of mine will say, is we create our own headaches. Let's talk about the unplanned hospitalization. This is an outcome-based measure. So again, you have to define what is the scope of the problem, what type of patients are being rehospitalized. You can't drink the ocean, so you have to chunk it up in bite-sized pieces that will let you understand where the disconnect is, where the gap is, and then follow after it. When are they experiencing rehospitalization, and then use what you know about rehospitalization to drive the inquiry. These are just, again, some of the key performance indicators that will help you understand and define the scope of the problem. What it'll also do is it will help you determine where you have to put your greatest resources, what you have to prioritize. So let me show you how this happened. In this instance, we were looking at 60-day unplanned rehospitalizations for a particular organization that I was doing some work with. And they just hadn't been able to get underneath it, and they were constantly breaching their threshold. So I said, well, what is it? Where is it? And when we drilled down a little heavier on it, looking at who, what, when, where, what we found was that a majority of the rehospitalizations were being driven by COPD patients who were admitted on a Friday to the agency. And when we drilled down even farther there, what we determined was that there were certain factors involved in the discharge planning process, in the pickup by the clinicians, and the assignment over the weekend. It had a huge downstream effect. The result of which was it skewed their readmission rate, and they were constantly breaching threshold. Now, what that happened with them is they were able to devote their energies and their resources to working on just that group, and just by working on that group have a significant impact. So let me show you about, let me just go back up 1 minute there. In this instance, what they ended up doing was really focusing on when patients with COPD were discharged. They were meeting with the discharge planners at the hospital. They actually had a check sheet that they worked with their pulmonologists to create. And so the physicians were appreciative, even though they weren't at all affiliated. This was a freestanding organization. They were much appreciative of the fact that they knew that these particular patients had a tendency to be a higher tendency to be rehospitalized, and so they appreciated the checklist. They worked the same checklist with the discharge planners in the hospital, so that until that complete discharge list was done with that checklist, that's when they started to bring them home. They also did some additional training with their weekend staff, and they created a a relationship with a pharmacy that to make sure that the patients could get their meds, because one of the things that they found is patients assumed that they could go back to using their existing inhalers, and many of those inhalers, this is just the unintended benefit, many of those inhalers had expired, or they were dirty, they hadn't been properly cleaned. So that was just some of the things that they found, and they were able to substantially reduce their readmission rate, come under their threshold, and actually became a preferred provider for some of the pulmonologists, another unintended benefit. So with the composite measures, this is the measures I mentioned earlier on that are a series of different measures that come together collectively, and they create a picture for performance. So think about creating a scorecard or a dashboard for these so that you can see a composite measure, the metrics that together form a composite measure in one infographic. That's really powerful for your leaders. If you're a PI listening to me, that's a really powerful way to show your CEO, your CNO, your administrator, your director of nurses just how your organization is operating, because they have in one picture where they're sitting. They can see, are we going into the green zone here? Are we trending out? Are we doing well? And actually, in some instances, marketing people can use this when they are, or your leadership can use this when they're entering into contract negotiations, because that dashboard is a valuable picture to your payers. So let's think about creating a scorecard for each of these: care of the patients, communications, and specific care. Now, you have to think about what are the components of the component metrics of each of the measures. And that can get, again, pay close attention. It can get a little bit tricky to do that. I know in some interviews with CMS, they've actually, when the questions come, well, what exactly is involved here? CMS has responded with, well, we're going to tell you about it. So we have to pay close attention to CMS. We have to pay close attention to any other payer, be it an insurance payer, whatever contract you may have, an ACO, Pioneer. So remember that for the more complex issues, if you're running into an issue, please be sure to drill down to the root cause, because these metrics get a little bit more complex, a little bit more complicated, and in order for you to really understand what's driving performance, you may need to get all the way down to root cause. Excuse me. So let's think about communication between the providers. And this is really between providers and the patient. So the medication orders are complete and accurate. Those same medication orders are communicated all the way through to the patient. If the patient has a question, can the patient reach their pharmacist? Can the patient reach their physician? Can the patient reach the nursing agency? Handoff communications. Think about, how the communications are handed off. Action on a complaint. What's your response time? What's your close the loop time? Are you feeding back all the way to the patient? And do you secure verification and validation from the patient, then the issue's been resolved? So if you're on the phone with that patient or you're in front of that particular patient and family, it's important to have the accountability and responsibility to ask the question, does this resolve your issue? Is there, and is there anything else I can do for you? Because you need that verification. That's important, especially in a patient-centered frame of reference. Response to a call or need expressed. The home health aide assignment and supervision can be a hidden repository of really good information about communications. Course discharge training and advanced care planning. I want to mention about the advanced care planning because that's a double, that you get a benefit there too, because that's going to be one of the new measures. We're very good, historically we've been very good in home care about determining advanced care planning needs and wishes on admission. But remember, as things change during the course of a patient's life, it's important to revisit those discussions and to have the conversation. Now, with a global metric, global metrics are perhaps the most difficult and challenging to get underneath because this really is run through the filter of the patient's experience. So what you really need to have is that more positive experiences for that particular patient move the dial up, and the negative experiences move the dial down. Now, that sounds like pure logic, and it is true. What is not logic, though, is what the patient values. And I offer you this just little piece of advice. Just because you value it does not mean that the patient's going to value it. So let's say, for example, that you happen to have an absolutely stellar reputation and performance record for getting to the patient on time. Your staff is magnificent about it. You've never breached it. And yet you may find that that's not the big deal for your patients, because sometimes a patient may not necessarily be ready at 9 o'clock. They want to push their visit back to 10. But your staff can't accommodate that, so they really need to get in there and achieve their metric. The patient becomes a little less satisfied. Yes, they were on time. Yes, they came at 10, or they came at 10 o'clock as I requested, but now they're in a big rush because they're late to go see their other patient. So I just caution you that just because you value a performance metric doesn't necessarily mean your patient's going to value it. And sometimes it can be quite amazing what a patient will value. Sometimes it is a kind word, a kind voice, the tone of your voice. I happen to be rather when I'm teaching, my voice raises when I'm trying to get a point across, and that may not meet the needs of a patient. Sometimes you have to moderate your tone. So just be sensitive to the fact, and you may need to drill down on what is the root cause of that particular experience that makes that patient satisfied. Just as another example, the ability to say, "I'm sorry," can sometimes move mountains. So understand that. Sometimes it is the ability to get the patient's physician on the phone or to advocate for the patient. Other times it is the tenacity of a clinician to properly reconcile those medications, or to be absolutely unrelenting in getting that dressing just right for that particular patient, so that the bandage doesn't come off or the colostomy seal doesn't break. It's just wonderful to see what patients do value. We could learn a lot from them, and we continue to do so. So here's your guidelines for your global metrics. Work to understand what are the key leverage points. Sometimes if they have a bad experience, just calling within the first 4 hours to apologize or say you're sorry or to reconcile it can make all the difference in the world, versus, letting it wait until the next visit. Sometimes it's, what is the key important factor? If it is the ability to access their physician promptly, a phone call to the physician to say, is there a particular time, or to work with those kinds of groups. Sometimes it is, I really cannot handle the therapist and the nurse on the same day. So understand what those key leverage points, and then help work, or I should say define what is the critical to have. What are those critical few things that they absolutely have to have? Understand the root cause. Sometimes it has nothing to do with you. It is frustration within the family. And I know, as I'm talking to you, any of you that have had experience in home care nursing like myself will know that sometimes a patient is having just seems to be having a really tough time with you, and it's not about you. It's about other things going on in their personal life, but you just happen to be the safe place where they can get rid of that frustration. So take that time to diffuse that situation, and then work to understand the root cause, and possibly get a social worker involved, or work to adjust your own schedule or your own work with that particular patient. But again, understanding that helps you define your metric. Utilizing, just on that subject again, defining and drilling to understand the root cause of the issue. Don't underestimate the impact of behavioral health needs currently. That's, you're seeing, raising awareness of that now. So be sure that you consider that if you're trying to drill down to root cause. Voice of the customer surveys and focus groups can really help you there. Just please be sure that you're not the one doing it. You really need a neutral third party, because we have what's called a bias. So you have a familiarity bias, and you don't want to run the voice of the customer through your own bias lens because you won't really hear what's being said. And then utilize the resources of your patient satisfaction company. And many of these companies have tremendous repositories of information and resources and can generate reports for you that really help you drill down and understand more about exactly what the voice of your customer is saying. So the likelihood to recommend is the Net Promoter Score. Realize with the likelihood to recommend there's some limitations on the population being surveyed because you're surveying a different population each period of time. So I would encourage you, anybody can access this information. We have a lot of information on the journey to high reliability. You can access that information on our website. Clearly, if you're already accredited by the Joint Commission, feel free. You can go in and access the resources that are provided to accredited only. But for anybody on this call, please, all you have to do is Google high reliability, and you can get a lot of information on what that really means. You'll hear now the conversation is turning to getting to zero, zero harm, zero patients having a bad experience, zero adverse events. It's a new journey that the healthcare industry is taking on. I always caution organizations to be aware of organizations that say we have a 99% satisfaction rating, because that really doesn't mean very much unless you understand what's the frame of reference for that particular measure. So let's say you have, an organization comes to us, you and I, we're in this one org, and they say we have a 99% satisfaction rating. Doesn't really understand, we don't really know what that means until we understand it within the context. What if when we go to this vendor pool, we find out that the average customer satisfaction score for this industry is 99.8%. Well, now that 99 doesn't look so great because they're kind of on the bottom end of that. By the same token, an average is just that. It's the highest and the lowest. And then you calculate the average. So the Net Promoter Score is really a more robust measure. And again, you'll see the resources for that at the end. I said it before, I'll say it again. Remember, the bigger you are, the tougher it is to move the needle for improvement. So if you only have 10 patients and you improve the patient experience for one of those, you've got a 10% improvement. But if you have 100 patients and you improve the patient experience for one patient, you only have a 1% improvement. And then just remember, are you really looking at a measure of your patient-centeredness? Really think about it from the patient's perspective. Sit in that seat, wear those shoes, and say, am I really getting what I wanted as a patient? So here's some resources to check out in terms of a Net Promoter Score, and then you can also there's the Huffington Post actually did a little thing about the value of measuring, and that'll give you some just some more information on Net Promoter Score, and then you make your decision based on what best meets the needs of your organization. Here's some information on high reliability for you as well. And of course you can pick any one of these. There's Becker's Hospital Review. Don't shy away from that, because we're really looking at healthcare systems, and as healthcare systems begin to take a real active role in value-based payment, it's important to understand how they're going to be cutting the measures as well, especially if they start to govern govern some payment direction. Of course, the QAPI and performance improvement resources, there's some right there from the QAPI, right from CMS. I gave you that website because sometimes you can, there's so much on the cms.gov website, you can be there looking for an hour. So I tried to lay that in for you pretty clearly. And then the last one there is the fee-for-service payment and the prospective pay downloads. You can also look at that as well. So that concludes my presentation for today. I hope that you have gotten some information that you can use in the next 30, 60, and 90 days, and please feel free to contact the VNAA if you have any additional questions, and they will route the questions to me. It's certainly been my pleasure, and I wish you all the very best of days. Thank you.